everyone. This is Dr. Major Harshita Surange from IPSC Pain and Spine Hospital, and today I'm going to talk about physics of musculoskeletal ultrasound imaging. So, image interpretation by ultrasound isn't that difficult. So, how do we do it? The probe, if we imagine that this is the probe, so the probe emits the ultrasound beams. Now, these ultrasound beams travel into the atmosphere, meet an obstacle, and are reflected back according to the reflectivity of that surface. For example, if my probe is kept here on this finger and ultrasound beams are emitted, my finger is going to, the various layers of my fingers are going to reflect back ultrasound beams. For example, the skin will reflect some ultrasound beams, the subcutaneous tissue will reflect some ultrasound beams, the underlying muscles are going to reflect some ultrasound beam, and so on. So these reflected ultrasound beams are again collected by the ultrasound probe and are displayed on the screen as echoes. Now, the number of echoes which come back determine the whiteness of the image. If more echoes are coming back, we get a hyperechoic image. That is more echoes. Hyper plus echoes, more echoes. If less echoes are coming back, we get hypoechoic image. And if no echoes are coming back, everything passes through that structure, then we get a anechoic image. So here you can see what's happening is the probe here is kept over the skin. As I told you, the probe is kept over the skin. So some ultrasound beams enter the skin and are reflected back. Some are reflected back. Some are reflected back from the subcutaneous tissue. Some are reflected back from the muscles, and so on. So what happens? You can see every layer is reflecting the ultrasound beams, but the remaining ultrasound beams are either refracted and keep moving to the next plane or get attenuated as they go deep. Okay, so there are structures which reflect back 100% of the ultrasound beams and a lot of echoes come back. Like the image is hyperechoic. But if a structure reflects back 100% of the ultrasound beams, what do we do? What do we get? We get a hyperechoic image, but we don't see anything posterior to it because there occurs shadowing posterior to it. So the amplitude of returning echoes, which represents white dots on the screen, are seen as 256 shades of gray. So here you can see this is the suprapatellar area and the probe is placed vertically or craniocaudally. That's the patella and that's the femur. Okay, so that's the cranial end, that's the caudal end. So when the probe is kept craniocaudally, what you see, the first structure to be seen is the skin right here. Then you see the subcutaneous tissue. Now this subcutaneous tissue has the black areas here are fat lobules, and these fat lobules are connected by interlobular septae. Underneath these lobules, you can see a fibrillar white structure. And this fibrillar white structure is going and attaching to this white structure right here, which is nothing but the patella. How do I say that's the patella? Because it's a white structure with distal sharp shadowing. Now, this fibrillar structure is the patellar tendon. On top of the patella here, you can see a echogenic area, and right in front of the femur also you see this echogenic area. Now these echogenic areas are nothing but suprapatellar fat and prefemoral fat pad. And between the suprapatellar fat and prefemoral fat pad, what you can see a recess here, black area, which is nothing but the suprapatellar recess, which is extension of the joint capsule outside the articular surfaces. So now coming back to the probes, we have two types of probes, which are high frequency and low frequency probes. The high frequencies have got lower energy for penetration, but have got high or excellent resolution, in contrast to low frequency probes, which have higher energy for penetration, but poor resolution. So coming over back, So low frequency probes for more penetration but at the expense of resolution, and they are meant for deeper structures. However, the high frequency probes cannot penetrate deep but have got very good resolution and are meant for superficial scanning of the structures. So we've got two types of transducers according to the make. We've got mechanical transducer and electronic transducers. The mechanical transducers are, as the name implies, that of two types, oscillating and the rotating uh, transducers, in which the machine on which the piezoelectric crystals is implanted either oscillates or rotates to stimulate the piezoelectric crystal to emit ultrasound beam. Then we've got electronic transducer, in which we have got two layers of electrodes in which between which is the piezoelectric crystal placed. Now these two layers of electrodes can be arranged in linear fashion or curvilinear fashion, or they can be in a phased array pattern. Now then, as we said, we have got high frequency probes and low frequency probe, but there are certain probes which are of broad range. When we say broad range, the benefit of the broad range is, for example, if you're wanting to do your shoulder ultrasound, you start doing it with the superficial probe to see the deltoid and the subscapularis muscle. But the moment you have to go to the glenohumeral joint, you need to reduce the frequency so that you can do a deeper work. So, without changing the probe, with the same probe, you can change the frequency and do deeper work as well as superficial job also. So various machines have made various types of probes, and some machines even have got probe of 2 to 22 megahertz, which suffice all your difficulties. That is, you don't need to go switch the probe again and again. But again, I always recommend that you should not be placing all your eggs in a single basket, because if you have a single probe of 2 to 22 megahertz and there is a breakdown, then you lose on everything. So it's always advisable to have 2 to 3 probes so that you can keep shifting from one probe to another. It does cause a little discomfort, but is much more effective way in a longer term. So the transducers are of various designs according to the area which we need to scan. So here you can see a hockey stick probe. This is a eco probe. Why eco probe? Because when we do eco, we do it through intercostal areas, and when we do it through intercostal area, we've got very small footprint, very small window. So we need a very small footprint probe to visualize the cardia. Then here you can see it's a curvilinear probe. Then these are the linear probes, different side frequency linear probes. We have got a transrectal probe, transvaginal probe. These are also called as endocavitary probes. So these probes are designed according to the area you need to scan. So now coming back, the linear probe or the high frequency probe, it forms a linear image because ultrasound beams are emitted in a straight direction. In contrast to the sector probe, the ultrasound beams are divergent. You see, they are divergent and in form of a sector. So these are known as sector probe. And the phased array probe, you can see the ultrasound beams are coming from a single point here and they're diverging. So the idea of this is for doing very fast moving structures like heart and with a small footprint. So here you can see the type of image created by is this is a high frequency probe and you're creating a rectangular image, and with a convex probe you create a sectoral image, and from a phased array probe you produce again a pie shaped image. Now there are different display modes in every machine. We've got B mode, which is also known as the black and white mode. This black and white mode is for the routine scanning which you do. We've got black and white with color, in which we can just put in color, not to colorize the image, but to see the movements happening in the image. And that is the movement which happens is mostly because of the blood. So you can see the blood flow. The M mode is for the motion. The Doppler mode is of three types: the spectral, audio, color, and we also have got power angio. Let me explain you one by one. So the B mode here, you can see it is a black and white mode in which everything is seen in 256 shades of gray. And every tissue is identified separately because of the different constitution of the tissue. This is the motion mode in which you see the motion of the walls, and you can see the motion of the various parts of the heart, maybe the AV wall, the atrium, the ventricle, and so on. Now we've got color Doppler. Color Doppler is to, again, as I told you, is to visualize the color flow. Now there's a scale there, that's the red and the blue. The red is flow towards the probe and blue is flow away from the probe. Remember, this is not arterial and venous flow. Then we've got something known as power angio. Power angio is summation of both arterial and venous flow into one color, and it is used to pick up very slow flow of blood. Now, spectral Doppler. Spectral Doppler is specifically made to see the spectral traces or the velocity of to detect the velocity of the flow. Now, here you can see there is a up stroke, then there is a down stroke, and there is a recovery stroke. So this is a typical pattern of an arterial flow as compared to the venous flow, which is continuous, phasic, and changes with the respiration. And here the spectral flow of an artery doesn't change with the respiration. So here, if that's another thing which we all need to understand, that if at all we are in dilemma that whether we are dealing with the artery or vein, and there is a aberrant vessel or something, then we should always put in the spectral traces, spectral Doppler, and see whether we are dealing with the artery and the vein, because that's the most sensitive and specific way of determining whether we are dealing with the artery or vein. So now, as I told you, when we're dealing with ultrasound, there are multiple terms. Mainly what we will be talking is hypoechoic, anechoic, hyperechoic, and all these terms depends on the number of echoes which are coming back to the probe. So if it is hypoechoic, the echoes are coming less. And why is it hypoechoic? Because it has got more of fluid content. If there is more fluid content, then it becomes more hypoechoic or black. If there's less fluid content, then it becomes whiter or hyperechoic. So here you can see that this is hypoechoic muscle. Here the skin is comparatively white. The subcutaneous tissue has got hypoechoic fat with interspersed septae. Here you can see the bone which is totally white. That is hyperechoic with distal shadowing. Here you can see the biceps tendon, that honeycomb appearance of a structure, and this is the biceps tendon surrounded by fluid which again appears black. So the crux is, you should remember, anything black has to be either fluid or blood or seruma. Okay, anything white has to be a structure which is less in water, and it can be fibrous tissue or it could be bone. How do we differentiate between fibrous tissue and bone? Is fibrous tissue, beyond the fibrous tissue you'll be able to see the structures, but beyond a bone you'll see only shadowing. And the various shades of hypoechoic depends again on the fluid content of the tissue, and that is why as we as we do the scanning of aged persons or elderly persons, it is pretty difficult to differentiate between tissues because everything becomes echogenic because of fatty infiltration. So now coming back to the ultrasound, we have got image orientation. Now the image orientation can be in short axis and long axis. So here you can see that's the scapula, and that's the humerus, and that's the long head of the biceps tendon traveling between the lesser and the greater tubercle between the bicipital groove. Now this long head of the biceps tendon, since it arises from the supraglenoid labrum, it carries a synovial sheet along with it, and hence has got a little fluid content around it. So this synovial sheet doesn't extend to a distal to much length. It is only in proximal 3 to 4 centimeter beyond the bicipital groove. So now if we have to scan this bicipital groove, we place our probe first transversely over the lesser tubercle and the greater tubercle. See, when you place it over lesser and greater tubercle, you see bump lesser tubercle, the greater tubercle, and between them there is a groove which lodges a echogenic structure with a hypoechoic rim, and that is nothing but the biceps tendon. Now, the principle of radiology is always see any structure in two views. in a short axis view and in a long axis view. In a short axis view, when you see it cut section, and in the long axis view, just turn the probe by 90 degrees and see it in the long axis. So that's the principle which applies to all musculoskeletal imaging. Whenever you are interpreting a tear or any pathology, you should be able to see the tear or the pathology in two axes. Now there are multiple buttons on the machine, which are known as the control buttons for giving you a beautiful optimized image. So number one button, which we'll be talking about, is the depth button, the gain button, the frequency optimization, imaging mode, and the focus. So let's discuss one by one. So the depth. So the depth button is to see, to increase or reduce the depth. To increase the depth, but when we say we increase the depth, it means that we see deeper structures first. That is, here you can see this is a scan of the thyroid glands. So that's the trachea, that's the right thyroid, that's the left thyroid, and here you can see the longest sculi muscle also right here. So you're seeing a deep scan. Now what happens? After scanning it deep, my target area is the thyroid. So now I reduce reduce the depth and focus on the thyroid. Okay. And once I focus on the thyroid, I see multiple small cystic areas within the thyroid. See this image and see this image. So this tells us whatever is your target of interest should fill in the screen, and it should be optimally magnified so that you can see it perfectly and visualize the finer details there. So continuing with the depth, if the target areas are the carotid vessels, tell me, is this image a good image? Or this is a good image, or this is a good image? So of course, this is the perfect image, because here the carotid vessels are too deep, they're too shallow. Here they are too deep, and this is just the right position. The target area should always be in the center of the screen. The second thing is, we again have got three structures. See this is a target area. So which target area can you see the best? Of course, the middle one. Why? Because see, this is the focus. The focus, just like a mobile cameras, if you focus on something, you get the best image out of it. The same way happens in the ultrasound. If this is the focus, so this focus should be right at the target area. See, the focus here is below the target area, so you don't see it that well. Here, the focus is above the target area, proximal to the target area, so you don't see it well. But here, the focus is right at the target area, hence you see it pretty well. So we have to ensure that our focus lies at our target area. Now, what does focus do? The focus converges the ultrasound beams to that point, so that maximum can be reflected back and you see it best. Now then the next button is the gain. So gain is equal to brightness. So when you are visualizing the images, doing a scan, then you should make sure that that there should not see this image. Isn't it too dark? So the gain is not enough. This is too white. The blood vessel and the muscles are all appearing white, and even you can see some debris in the blood vessel. And contrast to here, you can see the blood vessel and the muscle, everything appearing black. So it becomes difficult to differentiate all these structures. And when we come to this image, this is perfectly balanced image, because you can see the blood vessel also properly and the overlying muscles properly. So the gain should always be in the right row, so that you can differentiate each structure separately. Now coming over to the imaging modes. We have got red color towards the probe, the blue color is away from the probe, and power Doppler is merging of red and blue color to give it a red color to detect very slow flow of blood. So let's talk about the Doppler. So once when we are doing the Doppler, when you're putting color, to visualize the flow into the particular area, to see how much inflammation or vascularity that area has got, we don't get, sometimes you're able to pick up color, sometimes you're not able to pick up color, sometimes the color is all blooming or aliasing, so we don't get very good flow of color. So let's understand why. So there is something known as wall filter. What is wall filter? That you filter there is a filter which reduces the flow, which not reduces the flow but reduces the number of ultrasound beams. So if you've got a low wall filter, see what happens. If the wall filter is low, you get something like this. The color is all flowing right and left. If you optimize the wall filter, then the color remains into the vessel wall. Then see the size box. When the scanning box is large, you see that there is a aliasing and not that good flow. But when the box is small and compared to small and over the target area, then what happens? You see a much better pickup of the color. So when by reducing the box, you not only make the image optimal, but you also increase the frame rate. Now, what is frame rate? With the increased frame rate, here the frame rate is much more as compared to here, and it can be seen right here. Frame rate. Here the frame rate is 11, and here the frame rate is 17. Okay, so this has got a higher frame rate. That is, you can detect fast moving structures more accurately. Okay, then there's the direction of the box. You have to ensure that the direction of the flow, that this box is also aligned as per the direction of the flow. See, here the box is straight. You don't get that good a flow. So what you need to do is you align the box in the direction of the flow. So if the flow is in this direction, you just align the blocks in this direction and you get a much better flow in this area. Then there's something as known as blooming and aliasing. These are two artifacts seen in the color Doppler. Now, what is blooming? Blooming is too much of brightness. When there's too much of brightness, there's too much of blood flow, and the entire joint appears anechoic and filled with blood. And what is aliasing? Aliasing is when the PRF is too low, pulse repetition frequency is too low. There is mixing of colors. The arterial, the venous flow all get mixed together, and that is aliasing of the flow. So this can be controlled by PRF. So you should ensure that the PRF is adequate when you're doing a low flow ultrasounds, areas with low flow ultrasound or MSK ultrasound. Typically, your PRF should be anything between 3 and 5. Okay. Then there's something known as flash artifact. What is flash artifact? Suddenly there is a lot of blooming, right? And why does it occur? Because the PRF is again very less, and the artifact there because all red and blue color within it. And then there could be tissue motion noise also. You can see some flow, some color here and there, and this is nothing but because of the tissue motion flow, which happens because the tissue is moving or your probe is moving. So because of either of these movements, you get some flow in the structure, and you should not confuse it with the neovascularity. So this is optimal power Doppler. In power Doppler, we don't get red and blue flow. We get only single flow. But in some advanced machines, we also get red and blue flow separately, but it is used to detect very slow flow of blood. So for doctor to optimize, we need to keep the gain to clear. Gain should be adjusted for a clear visualization of the vessel without noise. PRF should be according to the vessel you are tracing. If it is a low velocity vessel or a small vessel, it should be typically between 3 to 5 centimeter per second. The wall filter should be slow for slow flow and higher to remove the motion artifact. The sample volume should match the vessel lumen. The angle correction should always be less than 60%, and small box leads to small focused area for higher frame rates. Now, high frequency should be used for superficial structures and low frequency for the deeper structures. For power Doppler optimization, more sensitive to low flow and microvascularity. That is when you need to use power Doppler. Use low PRF and low wall filter. We have already discussed that. Increase gain until. So how to check the gain? So the gain should be always be increased until there is a noise. Okay. And then you start reducing the gain so that the noise disappears. That is the place where you need to optimize your gain. Power Doppler is not angle dependent, so it is useful for joints and Please remember, very important point, don't put in excessive pressure, and the muscle which you are seeing or the joint which you are seeing should be in a relaxed position. If there is a tension pressure or tension over that joint, again you will not be detecting the slow flow blood. So common artifacts and corrections of color Doppler, there could be aliasing, there could be flash artifact, there could be no flow. So if there's no flow, reduce the pressure over the vessel, reduce the pressure over the scanning area, make the scanned area relaxed, and reduce the PRF, reduce the wall filter, and increase the gain. If there's a lot of blooming, lower the gain. If there's a lot of tissue motion artifact, adjust wall filter and reduce the pressure. So when do we call it a good versus poor Doppler setting? A good image has got optimal gain, low PRF, low wall filter, focus color box, minimal motion of the structure or the hand is done. And poor image when there's too high PRF and there's no signal, high wall filter, loss of which leads to loss of slow flow, and excessive gain which causes a lot of background noise. So now, after talking about Doppler artifact, let's talk about the artifacts in ultrasound also, because this is again very important. Because artifacts, we need to understand what are artifacts and how they are produced for right interpretation of the image. So we will be covering the advantages and disadvantages of the artifacts and how to differentiate artifacts from the various pathology. So medical professionals should be aware of the basic ultrasound physics to avoid and tackle artifacts occurring during imaging. So here what you can see is this is a patellar tendon and there's a quadriceps tendon coming, and you can see a lot of hypoechogenicity right here. Right, this hypogenicity goes away the moment you move, you tilt your probe in the direction of the tendon, and apart from that you do a more flexion of the knee. So by both the ergonomics and the tissue and the probe movement, you can remove the artifact which is happening because of the position. So why does artifacts occur? The machine makes 7 assumptions about ultrasound waves which do not occur and artifacts are produced. So echoes that do not, so all these, what are the different types of, why are these different types of artifacts produced? Sometimes echoes that do not correspond to actual structures. Sometimes we get echoes that are missing. Echoes are in wrong position or location. Echoes displays wrong site, size, and brightness. Some artifacts are useful for diagnosis. Other artifacts also hinder examination by obscuring, mimicking pathologies in the tissue. So let's understand that was too much, and let's talk one by one. So as I told you that this is over your lateral forearm. So when what you are seeing, you're seeing the brachioradialis, you're seeing the extensor carpi radialis brevis, you are seeing supinator, and what you are seeing is here's the posterior atrocious nerve. Now see, the posterior atrocious nerve appears almost blurred and hypoechoic because the focus is not at the place. And right here, the focus is right at the area. So how well defined and hypoechoic it appears. Okay, so again, we are talking about the focus. The second artifact is the anisotropy. What happens in anisotropy? When the transducer is over the tendon and the ultrasound beams hit the tendon and are reflected back at 90-degree, we get a good hyperechoic image. However, when the tendon is inserting at a particular area and are curved, then what happens? The ultrasound beams hit the tendon and are reflected away. And these reflected echoes do not reach the probe, and hence there is an echo drop at that particular place. So tendons elicit that property of anisotropy a lot. So here what you can see, that the transducer is right over here, and you can see a hypoechoic area right here, which appears like a tear or fluid collection in between the greater and the lesser tuberosity. With this could be a mimicker that probably the long head of biceps tendon is torn and has been replaced by fluid. But if you are aware about this anisotropy, you just need to tilt your probe, and what is going to happen? The moment the probe becomes perpendicular to the tendon, you start seeing the tendon echogenic. So see here, again the chylus tendon going and inserting onto the calcaneum, and there, because of the curve and the probe being straight over here, you see this anisotropy. Now how to remove this anisotropy? You just need to tilt the probe towards the insertion so that the probe and the tendon become parallel to each other, and the ultrasound beams hit it at a 90-degree. So again, another example of anisotropy. This is a peroneal tubercle, and here what you can see peroneus longus and brevis, and one of the tendon will always appear hypoechoic in relation to the other, and we should not make it a pathology, understanding that okay, that's an anisotropy which is happening because both the tendons are not parallel to the probe. In clinical imaging, refraction artifact may cause examined structure to appear wider or misplaced, or it may cause artifactually duplication of that structure. So now we will discuss about the two more common artifacts, that is a distal acoustic shadowing and distal acoustic enhancement. So in distal acoustic shadowing, first let's discuss about distal acoustic. There are three types of distal acoustic shadowing. That is when the shadowing occurs because of a clean reflector, strong reflectors which the ultrasound beams go hit and are reflected back. That is the strong reflectors. Then there could be, for example, if you are here, you are seeing a broken calcium deposition. So what happens? So this is a partial acoustic shadowing. Some shadowing occurs from this calcium, some from here, some from here. In between, the ultrasound beams go deep down. This type of shadowing typically occurs in the trachea. And then we've got dirty acoustic shadowing. What is dirty acoustic shadowing? You don't get a sharp shadowing at all, and you get shadowing, but not at all sharp. So distal acoustic shadowing, which is dirty, is mostly produced by air. So now see this sharp shadowing. This is the muscle. Oh, sorry, this is the bone, and this is the muscle, and within this muscle, there's this tendon, which has got this calcific speck, which is also causing a sharp shadowing. And see it here. What is seen here? Here you can see that there is a dirty shadowing. Now, why is this dirty shadowing occurring? Because there is some calcium deposit here and there in the vastus intermedialis tendon because of maybe myositis ossificans. There's some calcium deposition right and left, which is causing these shadowing. And then the air. For example, if you have put in the needle and then you're putting in some air has been deposited, see the dirty shadowing of this air which is happening. Now, the more about the dirty shadowing, there could be some artifacts of dirty shadowing. For example, when we are dealing with this type of dirty shadowing, okay, so these are also called as ring down artifacts. Okay, and then we can be having something like this, a cystic area, and on either side of the cystic area, you can see this shadowing. This appears like fluid collection or hypoechogenicity adjacent to the cyst. So we need to understand that this is a critical angle shadowing because of the sudden change in the angle, sudden change in the density of the tissue. There occurs reflection of there occurs a echo drop and also more of reflection back to the probe. Okay. The speed of sound is same in all tissue. This is a misnomer. We keep saying this all the time, but this is not right. So because speed of sound is different in bones, it is different in metals, it is different in glass, it is different in wood, it is different in soft tissues. So because speed of sound varies from structure to structure, there occurs some speed displacement. And this is again a very important artifact which you should be of understanding. Then apart from that, we'll have critical angle and refraction. We already discussed about the critical angle. Let's discuss about speed displacement and refraction. So now here, what is happening? You're putting in a needle right here, right? And the needle appears bent. Can you see this bend in the needle? Is this the needle bend? No, this is not. But you get this bend because there are areas of strong impedance and there are areas of low impedance. So in the area of low impedance, the needle appears bent. So please don't confuse this at all that you are dealing with a bent needle. You should be aware that there is something known as speed artifact also. Give me a minute. I'll just put in the changing point. So now another example here, you can see the critical angle artifact. This is a soft tissue mass, and on either side of the soft tissue mass, you can see this shadowing. This is the critical angle shadowing, which occurs because of the refraction. Okay, and you should be aware so that you don't make it as a pathology. You can think that there is hypoechogenicity, there's a tear, or there's a penetration, there's extension of the mass into the deeper tissues. Now, what is happening here? This is a Baker's cyst. And here in this Baker's cyst, you can see some debris right here. Okay. Is this a debris? No, this is not. This is again because of the refraction artifact, because when the ultrasound beams suddenly meet a structure which has got a different impedance, a very much different impedance, some of the ultrasound beams start reflecting from there. So this is what is happening because of the sudden change in the reflectivity. The ultrasound beams start reflecting, and it starts reflecting from all these area, and you start seeing this debris or this echogenicity, which may appear as infected cyst, but which is not. This is again a refraction artifact. Then we need to understand, are all echoes from the main ultrasound beam? No, because ultrasound probe not only produces the main beam, but it also causes side lobes. Okay, so what happens here? That this is another example. What happens? The transducer is right here, and when the ultrasound beam is emitted, it goes into the needle. Some are reflected back, and you see the needle, but some of the ultrasound beam pass right and left of the needle and go into the deeper tissues. And some of the ultrasound beam keep reflecting within the needle again and again and produces multiple shadows behind the needle, which are seen like this. This is again a reverberation artifact. And how to overcome it? You just change the angle of the probe. The moment you change the angle of the probe, these reverberation artifact will just vanish. Now, this is a metallic implant, and that's the bone, that's the knee. Okay, so this is the femur, and that's the metallic implant. What makes you think that there is not a distance of the, or the implant has not got separated from the bone? What makes you this gives a perfect email in for perfect visualization that the implant has been separated from the bone. But this is actually not so. Now, this implant, because it is metallic, it has got more better conductivity of sound. So it conducts sound faster and appears proximal as compared to the bone. So this is again a speed artifact which you should be aware and should avoid misinterpreting implant being loosened. So here again, in this hypoechoic area, you can see some echogenic foci, and from these echogenic foci, these you can see these comet tail or something, comet tail like appearance, these echogenic areas coming out. These are comet tail artifacts and are again seen in cholesterol deposits, which is a diagnostic that we are dealing with cholesterol deposit. Okay. Now here, see. Now this is again a implant, and this implant, when you place your probe over the implant, you get such artifacts, and these artifacts are again nothing but ring down artifacts because of the reverberation of the sound waves in the implant. So now this is again, yes, you thought it right. This is again a reverberation artifact. Now this is a video, and in this video, what I'm trying to show you is, see here, see, this is over the carpal tunnel. See the carpal tunnels, how hypoechoic the tendons are, right? And the moment when in doubt, you just put in long axis and you see them bright and echogenic. Now, shoulder. Very commonly, a patient comes to you with pain in the shoulder, and you put your probe and you see something like this. And what is stopping you from making it a supraspinatus tear at the foot plate? Nothing. So, but you have to orient your probe, you have to rock your probe in this way so that you see the supraspinatus in the complete and you can see that whether it is torn or not. But if you still see something like this, always move your probe by 90 degree and see it in the short axis. If there is a tear, it would be seen in the short axis too, right? If there's no tear, it will not be seen in the short axis. So always visualize the structure in two axes before labeling it as a pathology. Now the other example here, what you can see here, you can see a hypoechoic area or involving the articular surface of the supraspinatus tendon. Is it a tear? It could be, but this is not. This is happening. This is a very common artifact which occurs because these fibers, as you see, these curve around and get attached like this. Because of the change in the contour of the fibers, direction of the fibers, you can see because of this, you get this echo drop right here. So this drop here, please don't confuse it as a tear of the supraspinatus. This is just an artifact. So now, coming over to why do we need to do MSK ultrasound? Because MSK, most of the pathologies are not just intra-articular, they are mostly extra-articular also. Extra-articular, when you talk about extra-articular, it could be around the muscles, it could be around the ligaments, it could be at the enthesis, it could be around the tendons, it could be at the enthesiophytes, it could be myositis, and so on. So all the extra-articular pathologies can be visualized very well on ultrasound, and the role of ultrasound and the efficacy of the ultrasound almost is at par with the MRI when done in an experienced hand. Okay, then the other thing is that for extra-articular pathologies, you can always do a dynamic scan, a stress test to see whether there is a complete tear, there's a partial tear, or is it an impingement. So I'm going to stop here and stay tuned for my next video on, we'll be talking about identification of normal and abnormal tissues, advanced tips and tricks for needle placements, and patient selection and way forward. So see you soon. Thank you so much.